Welcome to the Heart of Healthcare podcast. I'm Hallie Tecco.
I'm Michael Esquivel.
And I'm Steve Krause. And every Monday, we bring you the latest in healthcare innovation as we sit down with entrepreneurs and industry experts.
So buckle up and join us as we figure out how to improve healthcare for all. Hello, listeners, and welcome back to the show. Today, I'm chatting with Mario Schlosser, co-founder and CTO of Oscar Health, the health insurance company that has brought a tech-first approach to the notoriously stodgy industry. Mario and his co-founders started Oscar in 2012 and since then have grown into a major player in the space, recently achieving profitability and expanding its membership to record levels. Mario, thank you for joining us today.
So fun to be here. Thanks for having me on, Hallie. Really great to be reconnected and talking.
Yeah, we have a lot to cover. One thing I noticed on the website, you and your co-founder said, we didn't start Oscar because we liked health insurance, quite the opposite. Can you tell us about what motivated you coming from gaming and software with no formal healthcare expertise to enter an industry that you didn't particularly like?
Yeah, that was Josh, co-founder, and my bonding moment early on. We had a coffee after our previous startup, more or less ended, at least for us. And we thought, what are some good ideas we should try to cover? And Josh said we should do a health insurance company. And it was a very spur of the moment remark because he had been in the ER with a sprained ankle after playing basketball. And then we're going with my wife through pregnancy for the first time. Our son was born in August 2012. And so that was right the time we started thinking about Oscar seriously. And
the most expensive healthcare event in someone's young life.
Yeah. And with not a lot of visibility as to what actually would happen there, how many ultrasounds are going to be authorized by the insurance company. This was the time when all these new cell-free DNA tests came out and you could test kids early on for trisomy 18, 21, things like that. Was that going to be covered or not? Nobody could tell us really. And so the insurance company just seemed incredibly useless in any of these processes and mostly to exist to somehow after the fact make life a little harder for you. And therefore we thought entirely from a user experience point of view, somebody really ought to build a more tech-driven, member-friendly insurance company. And only then we realized, the Affordable Care Act is coming and there would be potentially a market segment that would value these kind of things. And that was exciting to us.
Yeah. Looking back, now it's been over a decade. Now you're like the old guard in healthcare. What are the things that you would have told yourself starting off that you wish you had learned earlier?
The basic tension was always how much of Oscar should be built around basic health insurance competencies and how much should we build around ignorance of those basic competencies. That was always the basic tension. The first couple of hires after Josh and myself were health insurance people. We had a whole crew of semi-retired and retired guys who used to work for Emblem, a health insurance company in New York, which insures the local firefighters and policemen and so on. And we brought them in right away because we're like, what does an insurance company even do? And I had a chart after talking to these folks, but also other folks in the industry, where I mapped out all the various components you'd need to run an insurance company. Somebody has to do prior authorization, you have to have a claim system, you have to have a network management system, these kind of things. But we hadn't really ever stood these things up or even looked at vendors that would do this with us. And so we knew we needed to import those basic competencies. But then we also knew if we just go and do whatever folks tell us in this space, it's going to end up being like a small, shitty version of Aetna, which is not going to be exciting either. And so I'm not sure I would tell myself anything that differently about how to turn that dial. But I would certainly tell my younger self where the areas are where you just need to import the competencies and where the areas are where you should just not believe what others are telling you. Certainly one of the very simple things is we started in New York City. And New York State is the worst place to have an ACA healthcare plan for all kinds of regulatory and other and economic reasons and so on. And everybody told us at the beginning, like, why are you starting in New York? Start in Texas or start in Tennessee or whatever, or Florida for that matter, the biggest market today for Oscar. But that was a simple one and kind of still shows how little we knew about healthcare at the time. There's a famous story early on where Josh and I talked to a luminary in healthcare, and In fact, actually, I think I can say this, the Oxford founder. Oxford was sort of like the previous Oscar, if you will, a health insurance startup in the tri-state area in New York, New Jersey, and Connecticut. And we talked to the former CEO and founder there, and Josh would have his favorite line at the time, which was, we think it's a great asset that we don't know that much about health insurance. And people used to be like, oh my God, that's such a clever thing to say. And then Steve Wiggins said, Josh, the roads to success in healthcare is littered with the bloody corpses of people who said what you just said. And so Josh stopped using that line. And that is still a question to this day for Oscar. Where is that dial between importing competencies in health insurance and where do we have to reinvent things? And it's a very difficult line to still draw.
Yeah. I think across healthcare, it's always like, when do you push the status quo versus when do you kind of work within the system as it's given? And such a delicate balance. But if you're not pushing the status quo and not questioning why things are done the way they are done, if it's not done in a way that's efficient and good for patient outcomes, then it needs to change.
Yeah, exactly. And I think the other thing that is very easy to miss is that most the healthcare system does not have the same requirements on us that startups in healthcare have. Most insurers don't grow, 50% every year. Most insurers don't expand into new states every year. Most provider systems don't expand all the time and develop new products all the time. And that is very easily missable because the kind of processes and the kind of technology that the incumbents can rely on, which is often just hundreds of people sitting in a room somewhere following Stone Age-old processes, that does not work if you put it up against these kind of requirements. That's an easy way to blow yourself up in healthcare.
Well, speaking of growth, you ended 2024 with 1.7 million members, which was a huge step up from 1 million the prior year. Like what really drove that growth? And then how do you kind of maintain a consistent member experience while scaling so rapidly?
The ACA is, I think, an incredibly good market for a good consumer product because people really do make their own decisions and they can change their decision once a year. You can just go to a different health plan. And if you don't like the value for money you're getting from Oscar, you can go elsewhere. And same with other health plans. And one of the numbers I always like to look at is if you go and index the cost of health insurance back to 2018 or something like that, some year in the past, and you look at then how the lowest silver plan in the ACA across the country has evolved since then, since 2018 or so, that costs us up maybe 10%, something like that. If you do that same thing for the large employer markets, that costs us up like 50% or something like that. So you really have much more competition of value for money in the ACA than in the large employer markets. Again, everything else being equal, just comparing against itself. In the ACA, the deductibles haven't changed or anything like that. It's not that somehow this is a redistribution from the premium to the cost sharing or something. It really is all other things being equal. And it's not surprising because everything's transparent. The prices are on the websites, even the government websites. You can go to Stride Health, whatever, see it there as well. And insurers really have to grapple with pricing, with competition, and so on. So what typically drives our growth is a combination of pricing and of member experience and of network, those three things. And in the States, we perform best. We've been in there for a while. People know us. There's a real word of mouth. Often even when the brokers, which sell a lot of the ACA plans, the brokers say, yeah, go to Oscar. They're going to solve your problem. They know I don't have to call them. They're going to figure this out for you. They're really, really good to work with. And they pay me on time, the brokers on time as well. So that's an important aspect, the member experience really. The second one is then network. Do we have the right providers in the system? Insurers run a two-sided marketplace, if you will. You have to have providers and members and align all of that. And the third one is pricing. We do know that if we are not within, I'd say, $10 to $15 of the lowest price in a market, we have to have a lot of other special sauce in that market to continue to perform and continue to outcompete others. There's some markets where
they're price sensitive.
$30, $40, $50 PMPM per month higher than the lowest in the markets, and we can still grow nicely. But those are the markets we really have fantastic word of mouth and things like that. And so you kind of want that. So, I mean, this is really that's great about the ACA, and you
it's
don't need to satisfy
competition.
everybody. Yes, exactly right. Yeah, and you don't need to satisfy everybody. We have tend to have like a 15% market share or so in the states we are in. And that's also fine because part of being an individual insurance company means don't build a network for everybody. Don't build a product for absolutely everybody. It's okay for the insurers to occupy different positionings in the marketplace.
Yeah. Yeah. We recently had the Iora Health founder and former CEO on, and he suggested that health plans start selling multi-year plans because there's not much you can really do to change health within a year, but within 3 years, 4 years, you can really drive changes that bring down costs and improve outcomes. What's stopping you from doing that?
I think, I'll say one funny thing, and then a more serious thing. Funny thing is not that funny, actually, but I find it funny from a technical point of view. Like, why do we actually have annual enrollment periods? I honestly think it's an insurance company technology challenge. We've been on many regulatory calls where regulators say, hey, we're going to change, we're going to have 3 more days for enrollment, or we're going to change enrollment dates or something like that in the ACA. And you typically hear insurers groan because their systems aren't set up to rapidly respond to these kind of parameter changes. And so I really do think that we have annual enrollment periods, partly because insurers couldn't do it any other way going a while back. Now we do need at least annual enrollment cycles, right? If you just can get insurance whenever you're sick, then it's not really insurance. So that's important. But I do think there is in many places in healthcare, you see remnants of prior or current technological constraints that flow through to then how we do things. I think the HEDIS metrics are another good example. Might be an urban legend, or urban myth, but the HEDIS metrics, from I heard, came out of originally what McKesson, one of those EHR vendors early on, was able to get out of their systems. They're like, all right, this is what we can report on. Let's make those the metrics, as opposed to a really grounded way of looking at what does quality in healthcare really stand for. It's just a very dumb way for technology to get in the way of good policy. But that put aside, I think Rushika is probably the guy you're talking about, is exactly right. This is a huge issue in the US healthcare system, that nobody can take a longer term view. And it's a giant issue for things like, GLP-1s. It's a big issue for things like gene therapies, which societally speaking, make a lot of sense because you have a multi-year reduction in cost, quite likely, but don't end up showing up in anybody's P&L in a useful way at the moment. The annual risk adjustment game is silly in this way as well, right? We have to all recode everybody on an annual basis. If you're a member who is missing all of his or her limbs, you probably, that probably won't change as an example over the next year. And yet we got to go and get the code again. And so that is really holding the healthcare system back, I think, in big ways. I think the ACAs and ICRA are small steps towards this, by the way. If you at least give insurance companies the ability, or whoever carries the risk, the ability to do something real about retention and retaining members that get retained because they like the plan they're with, you already have a little bit more control about how long they will stay with you. And you have a bit more of a flywheel of saying, let me invest in your outcomes. And if you like this, if you see this next year, I'm going to invest more because you can stay with me. And the more, therefore, I think the more ICRA pervades the US health insurance markets, the more you're going to get this longer term view and this longer term perspective from the risk-bearing companies onto investing in people's outcomes.
For our listeners, can you explain what ICRA is and how Oscar is playing a role in creating ICRA plans?
ICRA was a rule change from the first Trump administration towards the end of the administration. It stands for Individual Coverage Health Reimbursement Accounts. And that's a mouthful, but it means something very simple. It means employers can now take money, put it into an HRA, which is pre-tax dollars, and then employees can use those pre-tax dollars to buy an ACA health plan. And that was not possible previously. Previously, in order to, if you're an employer, or to give your folks money to buy a health plan, you had to have a RISA health plan, meaning you had to negotiate with United Healthcare and say, all right, I'm going to buy you a health plan, or I'm going to self-insure, whatever else, and then I can do it with pre-income tax dollars. You couldn't just leave it up to people to buy their own plan. And the good thing is that this can be so-called on-exchange or off-exchange in the ACA, which means insurers could create all kinds of funky plan designs. And, Bloomberg wants to go and do ICRA, we could have 100 Bloomberg plan designs that any insurance company offers now suddenly. Others could buy that same plan design, but probably mostly Bloomberg employees would buy it, built around providers in certain ways and with certain benefit designs or whatever. And so I think it's the beginning of the unraveling of the employer markets in the US. I think that would be a great thing. because I do think that even startups in our space that right now still depend on the employer market, like digital health startups selling to HR departments or certain TPAs doing that, I think they would all prefer to live in a world where you don't have this odd middleman, the HR department, in the process anymore, but where you could really say, I offer a product. If you like it, buy it. If you don't, buy somebody else's.
Yeah. Well, and it certainly makes it challenging for small companies and startups if you have like 5 employees and you're distributed between San Francisco and New York, like finding a health plan, you're hiring folks that, deserve to have health coverage, but how on earth could you find a plan? And so it's exciting to see just more options that take the burden out of small businesses and give the same tax benefits to the employees. So it makes a lot of sense. And I agree. Yeah. I'm super bullish on it as well.
Excellent.
So
we doubled into this year. I mean, it's a little bit hard to understand exactly what is ICHRA because plenty of small companies don't even advertise.
QSERA is the predecessor, right? And I think people still kind of know what QSERA is, but more options, consumer driven. It's great. So a KFF poll found that more than 2/3 of Americans rate their health insurance as good or excellent. And that holds across all types of coverage, employer plans, marketplace plans, Medicare, and even Medicaid. So people are overall like happy with their health plans, but there still seems to be just like a very deep public animosity towards the health insurance industry right now. A lot of things that I'm sure you're very aware of. How do you make sense of this disconnect between like the individual satisfaction that people are claiming with their health plan and the industry's reputation?
First of all, I actually think it's hard to put the finger on the data there. I see those surveys too, and on the other hand, we also have plenty of NPS surveys which suggest insurers are more like around 0 to 10 NPS points, and I think that what happens.
I can't think of anything that's lower than that.
No, so I mean either
hospital
maybe,
food.
Yeah, exactly. Probably that's exactly, and even that's getting better in certain, but they charge pretty penny for it as well. It's hard to put the finger on this, and then of course I think the ultimate test of is this data showing something real or not was the murder of Brian Thompson last year, and the outpouring of support for Luigi in this. I just don't really think that if people were all so thrilled about what they're getting from the insurance company, the healthcare system at large, that the outpouring of that support would have happened. I mean, there is really something unbelievably deeper than even I thought. I mean, we've been telling the story of, you mentioned the quote from the very beginning, we started an insurance company not because we like it, but because we didn't. That runs even deeper than even I think thought. And again, this is sort of like our business to try to say we're not United Healthcare. I think one of the things that's happened there is that health insurance and healthcare, as you know well, has for a long time now been a very, very significant chunk of GDP. It's always, I mean, if you go 10 years back, it's been whatever, like 15%. Now it's 18, 19%, something like that. And 10 years ago, though, it was maybe easier to miss that still because deductibles were much lower. I mean, there's a statistic that shows that in, I think, 2010, less than 5% of Americans had deductibles over $1,000. Now it's like 60% or whatever else. And so unless you were very well acquainted with the system, you didn't maybe even realize how crazy much income it is sucking out of your life. And because 20% of GDP means that in some shape or form, we're all going to end up paying a fifth of our income towards healthcare, right? Not right now, not everybody every year, but really over time and over the average. And that, I think, is one thing that's shifted. That is much clearer now to people how insanely expensive the system is. It's still hard because in the employer market, you often don't even see what comes out of your paycheck long before your money even hits your accounts, right? Like a ton of stuff gets deducted and goes to United Healthcare for them to then deny your claim before it even gets there. But that is, I think, part of the issue that created this groundswell of hatred, I think, visceral hatred for the current system and for insurance companies there as well. Now, I think if it's insurance companies' job to lower healthcare costs, you really don't see it in the last 40 years. I mean, you just have to say they failed at that job. And a lot of people like to say providers also are part of the problem because they do revenue cycle management. For every time an insurer denies a claim, whatever, there's like another guy coding up a claim, right? True, but at least providers still deliver care and insurers don't. And so it is hard to pinpoint really what role do insurers therefore play in the societal construct that we've created for ourselves here. And I find that hard to put the finger on as well. And I think it's hopefully easier to say in the ACA, where insurers have just kind of live and die by how members like them every single year and how do they deliver, how they enable care delivery every year and how they pay for it. But it's hard to say overall. My picture there is that over time, this has to merge. I think providers should be the insurance company. I think providers should have a much longer term time horizon. We talked about that before as well.
Yeah.
If you like your local provider, if you like one medical or whatever, you should have one medical insurance, right? Just name a random name now.
Kaiser?
Here. Kaiser is what's
the pay-vider model.
Kaiser's never been able to take it out of California really in that way. I mean, they're in other states, but they're only the insurance company, right? They don't own the hospitals in a bigger way. Mm-hmm. But yes, there are examples. Geisinger is another good example, of course, that does this. And I think what works better. So that's going to be the big battle of healthcare in the next couple of years.
And how much of that does Oscar do today?
What we see is we have higher pressure on us, I really do think so, to show up for members in how we deny and how we manage claims, how we deny and how we manage care, how we build networks and so on. I think there's we have both more trust from that compared to others, and we do have a very high net promoter score. It's 60 or thereabouts in the last survey. And the fact that we're not the lowest priced in most markets we are in, we're the lowest priced only in 5% or whatever of regions we're in, but still have generally outgrow the markets every single year is a good sign that people seem to like what we're doing, we're putting out there. And so we have to understand how we show up towards the member in a bigger way than I think if you are Cigna, United, or whatever else, where you have all these middlemen between you and the member still. That's already the case. I also think we have a huge amount of work ahead of us there. I think that we're not always explaining well why something is a denial. We're not always explaining well what is happening with your claim. We have put a lot of effort and investment into controlling and owning our back office systems. Like we have our own claim system, our own system, and all these things. That makes it easier for us to show members what we see. Like just literally last week, we always, for a couple of years, we had the data on your utilization management, on our prior authorization decisions in the mobile app, for example. But just last week, we just said, we have so much more data about this. Let's just show it all to the member when it goes live in our internal systems. That's now all in the app. These things are not that hard to do for us, but we need to keep doing them at a very, very high clip. And so that work is by no means done, I think. I hope we get the chance by members to keep doing the work.
Yeah. In terms of denials, I mean, you mentioned that because I do think that's probably the point when people have the most frustration with the healthcare system is, I need this life-saving treatment and it's getting denied. And those are kind of the stories that you hear that the New York Times writes about, that people go to Twitter with and it goes viral. But obviously there has to be a line drawn in the sand by health plans of what's covered and what's not covered. What's even the approach for being fair but being empathetic?
Let me give you one example really quickly why it is necessary. And it's an example from Oscar as well. A few years ago, we thought, when we looked at our prior authorization statistics on physical therapy, we thought we're authorizing something like 97% of all the whatever cases that come in. We're saying yes to most of these physical therapy requests. Why do we have prior authorization on this? And that just seemed like somewhat silly. How much worse can it get even if we just said yes to 100%? Like that 3% you're saying no to, is that really going to move the needle in a big way? And so we got rid of it. This is, I think, from 2018 to 2019. And then what happened in 2019, though? And so wait before you praise me. In 2018,
the word got out and everybody went and got a physical therapist.
Yeah, exactly. Literally. So in 2018, I think 2% of members had physical therapy under Oscar. And that number went to 8%, I think, the next year. And so not explainable at all by denial rates. Not in no way whatsoever. There clearly must have been an incredibly strong sentinel effects of the prior authorization going away, and therefore providers saying, you know what, I might as well put in physical therapy for you. And it is very difficult. So that is just the case. Yeah. That is one reason why US healthcare is so expensive, because it is a system that will create its own utilization. Now, what is very difficult to put the finger on is what would have been the right level of utilization. Is it 2% or 8%? That one is very hard, is somewhat hard to say. And so to your concrete question, what can we do there? We have to have good guidelines. I mean, we have to have good clinical guidelines that say upfront what's going to happen when certain things come in. that I think is giving people clarity from the beginning is incredibly important. We have a big clinical team that does this and writes these guidelines. We use some guidelines like minimum cost guidelines that the rest of the industry uses as well, and so on. Then we have to run the process very well. We have to just really say, it's not going to get delayed. We're going to look at it. We're not going to make mistakes in the process and things like that. And there was a story I read about United Healthcare denying something just yesterday again that seemed just a process issue, not even like a providers disagreeing, but just a process issue. Something fell through the cracks in their messy prior auth operations. So run a really good process, which is why we own our backend software and processes and do this ourselves. And we're not by no means perfect there, but at least we know where to go internally to say, this is to get better. You have to organize it differently and so on. And the third thing is a certain DNA in the company of medical directors and nurses are not told you're managing costs, but are told you're managing appropriate level of utilization. And get quickly on the phone if you see cases emerge that are problematic. And when I look at some of the cases where we internally thought we did not handle this correctly, they often also start with these process issues and then don't enable the caregivers to make a better decision because they didn't realize that this member had called 10 times and had a certain issue and that wasn't entirely clear when just looking at the medical record and making a decision based on that. The final thing is actually, so let me add a fourth one to this list, is what do we do in prior authorization? What do we use that power for? And the majority of Oscar prior authorization decisions is not denials. The majority is rerouting and redirection. And I don't think we're that different than other insurance companies there, but nobody's really explained this well. And so I know we have to explain this better, and we're trying to work on some ways in which we put this out to the public. But the majority of what we do on the inpatient setting side, for example, is things like, does this need to be an observational stay versus an inpatient stay? Different ways the hospital can classify it. Should this go into this level of care, not that level of care? Should it be this drug or that drug? Should it be this follow-up of physician or that follow-up with physician? And those are often things where the healthcare system, I think if a provider knew what the difference in cost is there, which in one way or the other loops back to members, right? If costs go up, they go up for everybody. Providers knew how this would all flow through. They wouldn't make some of the decisions they're making. They would say, no, you absolutely should go here, not there. But they just often don't, most of the time don't. Yeah. And so this goes back to if providers also had the risk and they had great technology in the back ends to manage that risk, we'd be in a much better position as a healthcare system overall.
But we're in a fee-for-service world still. So there's just
so this will not go
completely
away.
Different incentives on both sides. Yeah. I'm curious on that note, how you guys are treating GLP-1s for weight loss.
We put fairly strict prior authorization requirements around it and try to be clear about that. We prior auth them for diabetes care management, and then we try to do that quickly. We have a diabetes plan design, literally, where we put more benefits like diabetes test strips for free into the benefit design. So we have a real interest in managing those cases better and well. And I think it's a great example, by the way, for in the Affordable Care Act, you can build very disease-specific plan designs as well. And they work really well. Like we have an asthma plan design. We have certain asthmatic benefits that can get bundled in as well. We have been thinking about... I'm an asthmatic,
so that's good to hear.
Excellent. Yeah, please join. We have thought about, can we create a GLP-1 plan design? And don't have anything to announce there yet, but I do think that's a really interesting pathway. We can't let this window pass us by, I think, as an industry and as Oscar, to say, here's something we can give to people and it will lower long-term costs. And so that math we're still trying to do, how we best get that done. GLP-1 industry will also change a ton. I mean, there'll be the first, oral, whatever, medications. There'll be more generic, more branded drugs, more generics coming. I think those costs will just keep going down relentlessly. Yeah. That'll put them more and more into the window of, wow, you can really invest in people and in people's outcomes here. But right now, prior authorization is quite strict, and our nurses and so on can help you with that as to when that will apply to you. It is one of the highest call reasons and benefit questions we get into customer service and into our nurses.
Yeah. Going back to the employer market, what do you think is happening there? I know a lot of employers experiencing like solution fatigue, a lot of employers, small employers moving to ICHRAs. How do you think that founders should be viewing founders that want to sell to employers? What do they need to know?
It is very tricky. I'll tell you one quick story. We were at a conference a couple of, maybe 2 or 3 weeks ago, so of one of the big benefit consultants. And the big benefit consultants, you would think might be conflicted on the ICHRA story because they have a big business advising HR departments on how to buy health plans, and might that go away if ICHRA becomes consumerized and so on? But there are several of the very, very big benefit consultants that I think have seen this is inevitably where it's going to go, and they're jumping in front of this train and try to drive that train as opposed to getting overrun by it in the next couple of years. And so this was a conference where big benefit consultant and then very, very big companies, HR, people who run the HR departments in those companies and run benefits in those companies. And Lewis, Oscar's head of sales, been at Oscar for coming up about 10 years now, I think, who's also overseeing our ICRA sales, he approached me after he came back and was like, holy shit, this is insane what's happening here at the moment. For two reasons. One is that the HR departments don't yet know exactly what ICRA even is and how to deal with the logistical challenge you still have. There's still so you have to pay individual bills, but as a group bill, it's sort of like in the weeds, still challenges to figure out there. But the second thing is they were surprisingly like, oh my God, sign me up. I wanna get out of having to tell my employees every single year, oh, the deductible's going up another $2,000, and sorry, your premium's going up by 10% and whatever. And this year will be a relentless rise of healthcare costs year again. And employers are in no way equipped to deal with GLP-1s and forget about gene therapies, whatever. That stuff's going to blow up all these contracts, if you will, employees have with their employer. In today's economy where people just change jobs every 2 or 3 years or whatever, there's no way any of these employers can in any way figure out how to deal with GLP-1s and so on. So I think there's a big kind of thing building and potentially bursting where employers will just look at costs. I think, who knows where the economy is going, and none of us should ever wish for a recession, but if we are heading into this, I think this will accelerate even further. Employers will be so much more focused on just the costs, and they will have very little patience for things like there'll be an ROI here. You have to pay a bit more now, but your diabetes costs will come down in 2 years. I just think that's going to be very, very difficult to justify. And so if you have a model where you're able to show, I can take risk on myself, I am a diabetes vendor or whatever, I'll take the risk, you pay me X, and if whatever, and then we have some kind of agreement on what the diabetic costs will be, or literally you pay me you pay me the whole monthly premium for the diabetes member, and then I'll, true me up on the ups and downs there, hit me on medical loss ratio targets. If you can do that, great. Employers will absolutely look for moving costs and risk to others. That's very hard to do. It's very easy to convince yourself that in the first 2 years you do it well, only in years 4 and 5 for it to totally blow up in your face. I mean, this is my other sort of truism or observation about digital health in the last 10 years. And you nicely said it, we're now the old generation already in this. Every risk-bearing startup in healthcare will blow up at some points. And the only question is, will they survive that blow up? Will they be too big to survive the blow up? Or will they be kind of right at the right level to survive it? And retrench in growth, take a year or 2, 3 maybe, get through that, and then really come back and show that they really can do it. It's almost inevitable because healthcare costs are so delayed. It's so complicated to figure out in-network from out-network and all these other kind of things that get in the way there. But you can almost pencil this in for everybody, and so don't make that mistake of selling ahead, taking risk on other people's risk, and then blowing yourself up and not being able to pull back when it's too late.
Yeah. But I heard you say that you have to focus on, right now is not the time to offer a benefit per se. It's time to offer, your value proposition needs to be cost savings.
I think it has to be cost savings.
Not having this nice to have thing that can attract employees, because who knows where the economy is going. It's all about the cost saving. But how do you do a cost savings that doesn't include some sort of risk sharing?
I don't know. I think that's maybe what you have to...
You don't have the answer for us.
Yeah, I don't have a good answer there. I think I do think that there's... Well, one is you should talk to people who've done this. I mean, definitely talk to Oscar, for example, call us up and happy to give you some advice there as well, how to think about this. Talk to other insurance company startups that have gotten through it, other risk-bearing companies, value-based primary care practices that have had some experience with that, right? I would bundle them into this package if they're all going to blow up at some points. And I don't even just mean this negatively. I just mean it's like part of what you have to plan for. The ChenMeds of the world or, Ioras of the world really who've taken risk in the past and have navigated successfully through it and with their own issues along the way. I think you have to maybe attach yourself to one of those folks, right? Try to go sell to the value-based care players. I think value-based care is going to keep going. Look a bit at what the regulatory framework will look like. I would not be surprised if the Trump administration leans more heavily into ICRA on the one hand, which means there might be more insurance companies you can go to and build a product with. But I also wouldn't be surprised if they lean more heavily back into direct contracting models. You might remember at the end of the last administration, you had these direct contracting models that they were proposing where, health systems could take risk in a geographical area and things like that. And if those things become available again, there's a lot of other entities you could partner with, like a health system saying, I want to take risk on Medicare, fee-for-service in this entire area. And then you come along as a vendor and say, all right, let me do that with you. I think that is a very valuable potential play.
Still an opportunity.
So, if you look at the yo-yos in healthcare, I think in the last few years, the payers were doing very well. Providers were getting crushed. That's really swung back over the past 12 months. Now providers are probably going to do better. Payers are getting crushed at the moment, right? In all kinds of, risk adjustment, all kinds of V28, in all kinds of ways.
Oscar had a great year.
Yeah,
hitch your wagon to the
true, but always the bar goes up every year. So hitch your wagon to the providers, perhaps, in a way that wasn't possible before.
All right. So my last question is not healthcare related. You're also on the board of Duolingo, which is one of my favorite products. I have over a 600-day streak. My son's 6th birthday was a Duolingo theme. I'll have to send you pictures of the Duo.
That's awesome. Please do, yeah.
We're a big Duo family over here. I have a sister in Pittsburgh, so lots of ties to that world. But anyhow, how does keeping interests and professional ties like outside of healthcare kind of help with your perspective and approach to Oscar?
So actually, for the founders who are listening, let me answer another question even first you didn't ask, but I think is related, and that's the question of conferences. I used to think, and then I will talk about the non-healthcare stuff, I used to think it is very lame for founders to show up at conferences all the time. Then you can't have a real startup if you're showing up in this conference and that conference and so on. And I certainly still think that is true to a degree. Like if that's what you're doing, being on the conference circuits, at some point there becomes a problem of enough in your own shop. However, I think I did this wrong in the first 6-7 years of Oscar or so. Healthcare is a system that is ultimately run by 100 people. Some of the hospital CEOs, some of the payer CEOs, maybe some pharma, whatever, and everything else. It is still incredibly relationship driven. Obviously Epic is a good example for how successful that model can be, right? Maybe not the technology you'd otherwise buy, but somehow the connections all, the relationships all there. And if you don't, I wouldn't say play that game, that sounds too negatively. If you don't build those relationships, you will have a much worse time with your company. Healthcare is not an industry where primarily you can sell on the strength of your product or your technology. I wish it were, but no industry really ever is fully that way, right? It's like these in healthcare is much less than, let's say, technology or social media or whatever else. And so it is actually quite powerful to be in the right conference, in the right setting, partly also because you get good ideas out of it. I mean, I've come to think that going to a conference is a high risk bet. It's a very asymmetrical bet where, yes, you spend some time, but it's not going to kill you if you spend 2 days with a group of people or whatever else. And you have maybe a low probability, but there is a probability of hearing one thing that'll be super powerful, that you didn't know before, or a relationship you make that you didn't have before, that will really change the way you think about your own company. That happened many times to Oscar. Meeting early on an important hospital CEO who then gave us a contract to go into estates, or talking about a certain way of framing Oscar so we could get different vendors on board or whatever else.
Yeah.
So that is something I would pay attention to. And the same is true for this out-of-industry stuff that I do. I always loved education.
So in the industry, go to conferences. Can you name a conference or two that you feel like is worth going to?
The Health Evolution Summit, I think, is the best one. That's invite only, and I think it's got somewhat expensive as well for startups out there. But they're trying to do a better job in making it cheaper for startups to go. So that's a really good one. You have a lot of high quality people go there. And people actually stay on this one. People tend to stay 2 days or whatever in the same place. It's not just like running around or whatever. So that one is a really good one, I think. Look, I hate to say it, but I think health, HLTH, can be useful as well. It is just, it's an incredible zoo, but people do really all go to it. And that one, the value there is not necessarily the talks you can listen to, but it's just in having 40 conversations very, very quickly. Yeah. And maybe out of one of those, you will have an idea where you're like, oh yeah, that is something I should really pay attention to now. So that one is, I think, good as well. And then there are smaller things like Josh gets founders of healthcare together every now and then, and some others do too. I'm sure you do. I'm in Rock Health. You guys have done a very nice job.
The Rock Health Summit every fall.
Exactly, and have done a very nice job in creating this group of people as well.
Of course, the JP Morgan Healthcare Conference is one that everybody wants the invite to.
Yeah, exactly. Yeah, that one you can stay outside of it and have the same kind of conversations, I think. But I think those are the good things. And make it a mix of startup and not startup. Like JP Morgan is not startup. Yeah. Rock Health is startup, more startup, right? But you guys have also all the important channels. So I think that's helpful. And then on the non-healthcare sides, I'm incredibly excited to be on the Duolingo board, and Luis and Severin, the two co-founders there, are super brilliant people. And I was super glad to get to meet them and that they needed some help on the board there from another startup in the trough fighter. And if you can do that, I think that's also great. I wouldn't do that too early. I really think I did not join any board outside of Oscar until I even took a different job inside of Oscar. There's one reason why I thought going from CEO to CTO might be good, because I can do more things like that as well. It might be good for the company. And being on the Duolingo comp committee, for example, I now chair the comp committee there, no problem at all, is super useful to understand what compensation looks like in other technology companies. And that is something that benchmarking is very hard to get. You need to talk to other founders about these things and maybe be on a board or so. And that can be instantly useful for your own business as well. Speaking of healthcare and so on, the guys who do that were not education people. They did not somehow do 10 years of education or whatever else, or 10 years of Duolingo and then go in there. They came from totally different industries, and goes back to founders in healthcare, companies in healthcare. You have to think about people outside of healthcare for incredibly critical positions inside your company as well.
Yeah. Well, and I think that we don't get enough inside of healthcare opportunity to build a brand that really resonates and delights with consumers, because we're starting from a place that's, the bar is very low, and it's also just like a very serious subject matter. So we don't get as much opportunity to do that. We don't have the sort of mascots, the beloved mascots like Duo, anywhere that I can think of in healthcare. But certainly we could probably do more than we do now.
I absolutely think so. There's a statistic that says that I think of all the marketing in healthcare, something like 30 billion every year is done by the insurance companies, and only something like 3 billion is done by provider systems. And that's also totally backwards, really, right? Because provider systems could build a bigger brand. And I mean, it was NYU and Hims in the Super Bowl ads, right? So at least that one. And I think that's also misguided, because NYU
Pharma does, though, right?
Pharma does, yeah, that's true.
I actually heard that this is a crazy fact. We spend more time watching pharma ads every year than we spend with our primary care providers.
Wow, that is really a crazy fact. Yeah, such a great point.
Yeah. And we're only one of two countries. Then us and New Zealand are the only two countries that even allow pharma to run ads. It's very interesting.
And that's, of course, also that those have been the most successful money-making businesses in healthcare, like Doximity doing pharma ads as well, right? It's like it's that's like what it's inflationary and pro-incumbency. And look, it goes back to the issues of incentives in the system, and I think ICRA might have a chance in fixing some of that and so on. But we got to kind of move those needles before this all goes back to real. I mean, this is what I do like about Hims, that you have a chance to build a brand there, and we should have more of that happening in healthcare, but then with the right business model on the back, and ideally a deflationary business model and an inflationary business model. Right?
Yeah. Great. Well, Mario, thank you so much for your time today. It was great chatting.
Yeah, great to chat as well. Hallie, good to see you. Thanks so much.
Thanks for listening to The Heart of Healthcare. If you enjoyed this episode and you'd like to support the podcast, please leave a rating and review. And don't forget to subscribe. The Heart of Healthcare is produced by Hallie Tecco and hosted by Michael Esquivel, Steve Krause, and Hallie Tecco. The show is engineered, edited, and mixed by Kyle Moore. Visit our website, heartofhealthcarepodcast.com, for show notes and details.
Find yourself looking for a new job or change in career? Monster.com is here to help. We are not only here to bring you job postings, but also AI interview prep and salary tools, expert career advice, and top-notch resume services. We've got everything you need to land your perfect job fit. Discover the magic of finding the ideal job with Monster.com. Your future starts now. Visit Monster.com today. Your next job opportunity is just a click away.